Welcome to this month's modules. This month we'll be talking about evidence-supported treatments for the eating disorders. We will be breaking these up into evidence-supported treatment for bulimia nervosa and binge eating disorder, followed by anorexia nervosa. I want to take a minute to talk a little bit about the importance of the multidisciplinary team when it comes to treating eating disorders. I know in my work on a daily basis, I interface with my team, and every member of my team is so important and so integral to the overall potential for success of the clients that we have the honor of treating. On my team is myself, and I am a clinical psychologist. There is also a registered dietitian. There can also be a psychiatrist who is managing psychotropic medications as needed. There is also an MD who is expert in the medical monitoring and evaluation of eating disorders from a physical perspective. And these form just a few members of the team that are all really important. I think it's helpful for each member of the team to know about the treatments that are evidence supported for eating disorders so that they can work together. I realize that the psychologist is the one that administers these treatments most of the time, and some of these treatments have a lot of similarities with some of the approaches that registered dietitians use as well. But I think it's so important that we know what one another is up to and know what one another is doing in their office. Of course, we can't do one another's jobs. I could never do my physician counterpart's job or my psychiatrist counterpart job, but it's so helpful when we're all on the same team working collaboratively together. And part of that is a shared language. And I do think that this shared language of the therapeutic modalities that you might be working in makes life easier, not only in your efforts to collaborate with these other team providers, but also for your patients, so that the language that each person uses in session with the patient is relatively at least the same and doesn't overwhelm or confuse the patient in his or her journey towards recovery. I realize that the research literature has included RDoC, which has expanded conceptualizations of treatment to be transdiagnostic, which has led to a lot of great work in our field. For the purposes of this presentation, however, we do find it easier to present these types of treatments to you by the ones that have been found evidence for certain disorders. So today we'll begin by discussing those that are supported for bulimia nervosa and binge eating disorder. We'll be discussing CBT, CBTE, and interpersonal psychotherapy and dialectical behavioral therapy. So let's begin with CBTE. CBTE is deemed to be an efficacious treatment for the treatment of both bulimia nervosa and binge eating disorder, and it has been recommended by NICE, which is the National Institute for Health and Care Excellence. This is an organization based in the UK that offers evidence-based guidance and advice for treatments of a wide variety of health conditions and is well known for their helpful, poignant summaries regarding evidence-based treatments for eating disorders as well. CBTE and CBT before it are the most commonly, I would say, referred to and known treatments for eating disorders. And indeed, they have been quite well studied over the past several decades. However, there are some limitations with CBT and CBTE that are important to note. Unfortunately, like all of our current treatments for eating disorders, nothing works 100%, as we know. So there are some patients who remain symptomatic at post-treatment and follow-up. Because cognitive behavioral therapy requires a therapist to receive extensive training in the therapeutic delivery, usually the person has an advanced degree, has undergone this extensive training, and is also quite expert in eating disorders themselves. It is thought to be expensive for all of these reasons. It also can be time intensive to deliver. Oftentimes it's delivered over the course of several weeks in individual one-on-one psychotherapy with that expert I referred to earlier. Because of these things, it has been thought to be modestly limited in its dissemination and patient access potential. Which brings us to CBT-guided self-help, or CBT-GSH. Several studies have shown how CBT-GSH is equivalent to CBT in terms of eating disorder symptom remission at post-treatment and follow-up, and that is up through 24 months. Also, their dropout rates of up to around 30% are similar in both CBT and CBT-GSH. CBT-GSH is thought to be cheaper because, one, doesn't require the amount of sessions nor the session length per session that is often required in full-fledged CBT. Also, that advanced degree holding expert trained clinician is not required for CBT-GSH. Most of the studies, in fact, utilize individuals to deliver the treatment that don't have these requirements. CBT-GSH is also recommended by NICE. This slide shows a CBTE map. As you can see, it's labeled there. I want to note that these and several other of our CBT slides were gathered from credooxford.com, as you can see down there at the bottom of the slide. credooxford.com is a fantastic resource for those of you who are doing CBT or are interested in learning more about it. The creators of the website have offered several handouts and worksheets that are easily downloadable and printable for use in your therapy. So I invite the interested listener to check that out. Let's review here the map that we've got. Stage 1, starting well. Indeed, in stage 1, you are beginning the therapeutic relationship with your patient. There is a wide variety of assessment that goes into that. The assessment there is so important in CBTE because you really want to develop an individualized plan for the patient that fits within the overall scaffolding and frame of CBTE. Stage 1 also involves what CBTE is very well known for, which is the regularization of eating patterns. That is beginning to work on reducing dieting behaviors, establishing a structured pattern of eating throughout the day, etc. Once one moves through stage 1, they move into taking stock, which is a bit of a review of how things went in stage 1, as well as collaborative planning by the patient and the therapist for stage 3. As stage 3 is sort of the meat and the potatoes, if you will, of the work. There's a wide variety of things, as you can see there, that one would work on. Body image concerns, so body dissatisfaction, for example, or obsessionality with body checking. Dietary restraint, this might be additional ways that the individual is continuing to restrict their intake. And third, as you can see there, events, mood, and other eating-related concerns. Some time can be spent here in stage 3 working on these maintaining factors of the eating disorder and really trying to get them reduced. Towards the end of stage 3 and stage 4, you're really shifting the focus of therapy and you're beginning to kind of review what's been helpful so far, orient the patient towards thinking ahead and planning for the future, and of course, relapse prevention. Let's talk a little bit about CBTE techniques and strategies. Of course, there is the CBTE formulation, which I will show on the next slide and talk about with you a bit further. Self-monitoring. Well, this is what CBT is quite well known for. There's a wide variety of ways to use self-monitoring, and we'll discuss that too. Some people, it's important to self-monitor food intake, but some clinicians, depending upon the personalized plan of the patient, can also use monitoring for body checking, etc. And I can give an example of that as we move forward. Establishing regular eating and weighing is also one of the key techniques in CBTE. Alternative activities. These are activities that can be done in response to binge urges after regular eating has been established, and it's helpful to have a list of those at the ready for your patient. Psychoeducation is a really key part of CBTE, and this manifests in different ways, but essentially throughout the course of treatment, the therapist will be educating the patient about the nature of the illness, nuances involved with the illness, facilitating insight about how these nuances may manifest in the patient's specific case. And really there's a discourse and there's a dialogue around learning more about the eating disorder and helping the patient to gain a great deal of knowledge there. Overall in CBTE, of course, we're addressing concerns about shape and weight, body checking and body avoidance. Body checking For those of you who may be unfamiliar, are repetitive behaviors that involve sort of obsessively scrutinizing a particular aspect of one's body. For example, I've seen patients who will take their fingers and kind of wrap them around their thighs or their forearms or their upper arms to try to check, quote unquote, if they've grown or if they've shifted alongside the weight gain in the therapy. We do address feared foods or food rules that may be present in these eating disorders. So, for example, I don't eat carbs or sweets, something as broad and sweeping as that, or something like I will only eat a sweet if it comes from X bakery, because then it's only then is it worth it, so to speak, quote unquote. Indeed, we do address dieting and CBTE. We talk about managing triggers. We also can mood monitor, and as I mentioned in the previous slide, relapse prevention is a core part of the treatment as well. This slide depicts the CBTE basis for the formulation, and I've got to tell you, it is so helpful to have a pen and paper with you in session and to do this collaboratively with your patient, and not just once, but do it a few times. By doing so, you're doing two things. One, each time you draw it, you're reminding the patient of the theoretical foundation for the work that you're embarking upon together. That's meaningful because it facilitates insight into their own behaviors, and over time, you may hear your client even offer things like, oh, well, I realized that binge eating episode happened because I didn't get enough to eat earlier in that day, and I know that that sort of restriction can lead to binge eating. So it's fantastic, again, to sit with a pen and paper and quite overtly and frankly in session, draw this out as it's tailored to your individual client's experience. But let's walk our way through each component. CBTE hypothesizes that a lot of the initial problems that arose with eating were a result of overevaluation of body weight or shape. And for the most part, across society, when people are very worried about body weight or shape, they may initiate dieting. And of course, in eating disorders, it gets to be really disconcerting, the type and the nature of the restricted intake that they engage in. So what are different forms of dieting? Helpful ways to think about this can be broken down into three categories. One is that someone may limit the type of food that they eat. I gave an example earlier about avoiding sweets or carbohydrates. So that would be like a limitation on type. It may even be more specific than that. I don't eat X type of cereal or X type of bread. I don't eat white bread, or I don't eat chocolate. Another manifestation of dieting aside from type is portion. So perhaps someone used to allow themselves to have their entire sandwich, but now they only allow themselves to have half. Another manifestation of dieting can be frequency of eating throughout the day. People may have food rules about this, timing rules about this. So I don't want to eat anything before noon, or I only eat breakfast and dinner. And they really are limiting the frequency of the amount of time that they eat throughout the day. So those are all the different types of dieting that you're trying to explore together with your patient. So as you can see, the overevaluation of shape and weight can lead to dieting, can lead to binge eating, of course, because there's a physiological and a psychological deprivation that can occur subsequent to the dieting. Then, as indicated here by the subscript F, the letter F, there is a reciprocal relationship between compensatory behaviors and binge eating, and they can feed one another there. Importantly, we see this box to the left-hand side about events-associated mood change that influences binge eating overall. So again, all aspects, every single one of these boxes is really important in your work with your client. I invite you to not just list them out as they are here, but use those areas of the superscripts to specify how in particular that works for your patient. The more personalized this formulation become, the more powerful it is as a tool to use in your treatment. This slide depicts a food and shape checking monitoring form. As I mentioned earlier, monitoring can be done for food, which is the primary thing it's used for in CBT, but it can also be used for shape. So I chose this slide to highlight that, as sometimes people don't think of using their monitoring form for body checking as well, but it can be extremely helpful and insight producing. So let's take a look at this record here. As you can see, it's divided into several columns. These are very standard columns that we see in CBTE records. We've got a time column, food and drink, the place where it was consumed, an asterisk. An asterisk indicates the patient's perception that it was excessive, what was eaten. Here we have a column for checking, so that facilitates our monitoring of that particular behavior, place where that was done, and associated context and comments. There's so much that can be derived from this brief form alone. One thing we can see in terms of just looking at food is that there are no snacks really being eaten between breakfast and what appears to be lunch, the coffee and the muffin and the turkey sub, nor between the turkey and the sub and the 8 p.m. meal, which appears to be lunch and dinner respectively. So there can be a discussion there about snacks, access to snacks, etc. There could also be a discussion here about the excessive eating episode as indicated there with the asterisk and how that is subsequent to the lunch and how that correlates with the fact that it was 8 hours between the time the turkey sub was eaten and the time that the binge episode occurred. So those are just some examples of things that can be discussed from this record alone when looking at food. But if we take a peek at shape, we will also see that some really interesting things are happening. So this individual here, as indicated in the orange font, pinched stomach and studied themselves in the mirror at 8 a.m. So they haven't had anything to eat or drink yet, and they're already doing this, and it's taking place in their bedroom. So it would be helpful here for the therapist to inquire about this. Is this something that you do every morning? Is it something that you do while you're still in your pajamas? Or perhaps it occurs while you're changing out of your pajamas into your daytime clothes, or maybe it's before you get into the shower. Noticing that the day starts off with body dissatisfaction thoughts like I am disgusting and nothing fits. Then very helpful to review at the bottom there in orange font again that this person weighed themselves at 10 p.m. at the very end of the day, and it led to feeling hopeless and tears being shed. And so that's another opportunity to process a little bit about what were the body dissatisfaction thoughts that were occurring at that time, what's the utility of weighing yourself in this manner, etc. Let's move on and talk a little bit about avoidance. The previous slide was tracking body checking, but as clinicians may be familiar with, some of our patients obsessively body check while others distinctly body avoid. So this slide is highlighting some things that you might be able to do to address perpetual chronic body avoidance. And what do I mean by body avoidance? I mean not looking at yourself in the mirror, avoiding mirrors with fear, not looking at your body while you're changing. Sometimes people avoid even looking at themselves while bathing and while sort of washing their bodies in the shower or in the tub. To the left hand side, the left bottom part of the slide, we can see that there's a cycle here that's depicted about how avoidance can perpetuate beliefs about the self, how that may have a subsequent ramification on one's social interactions and their interest in being social, as well as making selective clothing choices. I have had clients, I'm sure as many of you have had, who've shown up in the heat of summer with a couple of layers on, including a very large baggy sweatshirt. That might be indicative of body avoidance. And this can lead to despair and an ongoing dieting, and so we see the cycle go round and round. CBT would invite you to acknowledge and talk about this pattern of body avoidance with your client, and perhaps collaboratively generate some ideas for exposure. Perhaps your patient can stop dressing in the dark, for example, and only dress in well-lit rooms. They can stop avoiding the touching of their body, and they can increase general body awareness. So these are some ideas about questioning avoidance and skills that a therapist can use to address it. This slide depicts how to talk a little bit about the overvaluation of control over eating. Again, as you can tell by the bottom reference, this was borrowed from the credooxford.com website. And again, the interested listener is most welcome to go there to check out all of their fantastic forms. The purpose of discussing this with the patient is really to facilitate, again, that insight about how their degree of control over their eating behavior has consequences in a wide variety of areas in their lives. As we know, as indicated by that far left bottom box, over-evaluation of control of eating really can foster dietary restraint. Next, checking control over eating interfaces with the over-evaluation. Here we see calorie counting, food weighing, etc. And for clinicians who have worked with eating disorder patients, you'll know that the outcome of calorie counting, that the outcome of food weighing is an increase in obsessionality about calories and the weight of food. So it is a never satiated venture to calorie count in this way. And I found one of the things that's been hard for me is my patients are phenomenally smart folks who memorize calories. So even if they're not trying to count calories, they're so good at it, and so they've trained themselves so well at it. So sometimes it becomes quite automatic to look at a sandwich and be able to surmise, for example, how many calories are in that sandwich. So if your patient is at that point where they're so quote unquote good at counting that it comes so quickly to them, this is another area that's really important to address. As you can imagine, over-evaluation of control of eating also leads to an increase in preoccupation with food and thoughts about food and thoughts about eating. Importantly, can also cause marginalization of other areas of life, as people may not want to go out to eat with friends, may not want to go to friends' homes or restaurants, and for fear of not being able to control what things are made, what's presented, and how they're prepared. So again, overall, this slide is a really nice depiction of how to begin to discuss things like over-evaluation of control over eating with your patient. Thank you for your attention to this CBTE portion, and you can check out the next module for this month. Last, here are some additional CBTE resources for the interested reader. These are also listed on the evidence-based treatment PDFs that are available to you in your resource section this month. Thank you for your time.